In this section we're going to be talking about data collection. Now perhaps I should make clear at the start that the word data collection is really inappropriate. It makes it sound as though data is lying around and all you have to do is to go and pick it up and pop it in your bag for later analysis. Particularly in qualitative evaluation exercises, a lot of the data will not be apparent. It will be hidden away. It will be in people's heads. It will be in documents that you don't necessarily have access to or even knowledge of. So a lot of the work of an evaluator will be rather like that of a journalist or even a police investigator. You may have to hunt down your data and look in some fairly unlikely places to find it before you can use it. A qualitative evaluator is not someone who is blinkered in terms of ignoring other sources of data. A good evaluation starts from the point of view of how do I answer the questions that I want to answer, not by what kind of methodology do I want to use. So we're led by the questions, not by our own preferences in terms of methodology. So a good qualitative evaluator will certainly look for documents that can provide the background and lead them into the project. They will look at the routine data systems to see what kind of information is available there on the finances of the project, on the clinical records of the project, the reports that are regularly produced, the M&E data systems that have been built into the implementation of an intervention. And they will use this data because it may be the best way to answer specific kinds of questions that they need to answer. They will also look for existing background surveys, the DHS surveys, the World Health Survey and so on, in order to provide background. They will ask if there have been any sample surveys maybe undertaken by those implementing the project as part, for example, of the M&E system. They will undertake qualitative exercises within that framework of other information sources. So the key point here is that because you happen to be working in a qualitative paradigm, it doesn't mean that you have to be blind to all the other sources of information that will support you in undertaking your qualitative evaluation. And a good evaluator will happily use whatever sources are best suited to answering the questions they want to answer. And they will cross-check one source of information with another. They will triangulate to decide for themselves what their final picture of the intervention looks like. There are a number of misconceptions about qualitative methods that I thought I should address. The first is that qualitative methods are only used by certain kinds of evaluators. In fact, anyone doing an evaluation will employ qualitative methods. Maybe not very well, but they will certainly employ them. So every evaluator will do a document review. Every evaluator, we hope, will keep their eyes open. They will see the queues or lack of queues outside clinics. They will see the dilapidated state of the local hospital, and they will draw inferences from that which will influence their evaluation process. Even if they're geared up to do large-scale surveys, even if they're geared up to do large-scale analysis of M&E systems. They will talk to people, they will conduct interviews, and those interviews will influence the way in which they perceive the project. It will influence the way in which they undertake their evaluation activities. So everybody actually does qualitative methods. Some people use them more than others. Some people rely more heavily on them. Some people do them rather better than other people. Qualitative research is, again, contrary to some people's expectations, and particularly maybe to my students' expectations. Qualitative research is more difficult than quantitative. The difficult part about quantitative research is designing the research process, designing the research instruments. Qualitative research is much more difficult when you're actually in the field. It requires a much greater level of skill. It requires preferably some expertise, because qualitative research is much less structured. That flexibility means that people have to be able to think more clearly. They have to be able to act when it's clear that they need change of tactics, for example. And that is done well by people who are skilled in this area, and very badly by people who are not skilled in this area. So the actual fieldwork in qualitative research is typically much more difficult. Qualitative records can generate quantitative data. So when we're talking about qualitative evaluation, that doesn't mean that we only end up with qualitative information. It's perfectly reasonable to collect quantitative information using qualitative methods. To give one simple example, I very regularly use village mapping, and village mapping can provide you a lot of quantitative information telling you about the demographic structure, for example, of a community, sometimes the poverty breakdown of a community, and so on, in quantitative terms. A point which I find very hard to get across is that qualitative data collection is not incompatible with statistical sampling. I recently undertook a very large-scale survey in China where we used statistical sampling techniques to take a sample of around 3,000 households, and the main purpose there was to find among those 3,000 households a number with serious illness, and we then use qualitative techniques in order to gather information about those households with serious illness. Because we had sampled the households using standard statistical techniques, we were able to scale up our findings to a much higher level, to the provincial level in China, using statistical inference techniques, even though our data had been collected using qualitative methods. What are the advantages of using qualitative methods? Well, I think possibly the main one is that you have a much greater degree of control as a researcher over what you do. With large-scale surveys, for example, the people involved in collecting data usually have much larger teams. They're usually much less qualified. You have to teach them how to collect the information, for example, using questionnaires. You have to arrange the logistics of the exercise. You have to find accommodation and transport and all the other things which go with a large-scale activity. In qualitative research, we're usually dealing with much smaller samples. So there are fewer people involved, both in the research team and in terms of the number of beneficiaries or care providers that we're going to be talking to. So we spend more time typically with each of our respondents. We have a greater flexibility about how we allocate our time. We can change our minds in the field. If something happens in a particular hospital, we can go to that hospital and we can talk to the people who were involved in that particular event. We are not constrained by having a plan which has to be unrolled according to a particular timetable. We can change our minds. We can get together with our colleagues and agree on changes in strategy and tactics and so on. It really is the only way to conduct in-depth explorations of people's perceptions, for example, of how they really feel about an immunization campaign, for example, their attitudes, whether they feel that people are treating them appropriately, whether they feel that things are being done for their benefit or contrary to their interests. Even to the extent of asking them about their emotions. How did it make you feel when you were abused by the attendant at the clinic? And we can address sensitive issues. Sometimes, if the researcher becomes a reasonably trusted person in whom people feel they can confide, then we can address sensitive issues around stigmatizing diseases, around power structures in the household, and so on. It is very comforting sometimes to be able to see what's happening. I can remember a number of occasions in my career when I've had long conversations at the Ministry of Health, and they've described the way in which their health services function and how their clinics operate and the staffing levels and so on and so forth. And then when you go to the field and you look at what's actually happening, you get a completely different picture. And because you've seen it for yourself, you've seen the absence of drugs on the shelves, you've seen the antagonism between the provider and the intended beneficiaries, you're fairly confident. You now know more about what's going on than you could glean from the informants at the Ministry of Health. One enormous advantage the qualitative researcher has, the qualitative evaluator has, is that there's much less need to be absolutely clear about your concepts before you go into the field. You're allowed to refine your concepts as you're undertaking the field work. So you can gather information and at the same time be rethinking your hypotheses, be rethinking your concepts as you go along. In the survey I just mentioned, I was keen to look at serious illness, but it's actually very, very hard to define serious illness. When you're in the field and you're talking to people in households, you can often decide if a member of the household has a serious illness, but it's very difficult to come up with a form of words which will allow you to capture that concept on a questionnaire form, which is going to be distributed to 3,000 households. Qualitative evaluation scores very heavily in terms of explaining why interventions succeed or fail, often with very large-scale quantitative studies. We can come to the conclusion that the outcomes from a particular intervention, the number of people helped, the number of immunizations carried out, the number of bed nets supplied or whatever, either did or did not meet the expected targets. However, if we want to know why it didn't meet the targets, or why it succeeded to a much greater extent than we expected, the answers typically can only be gleaned from qualitative evaluation techniques, talking to people, asking people how things happened, observing what happened, forming hypotheses, changing hypotheses, exploring the implementation process, and deciding what the underlying factors were in success or failure. There's also a factor which I've labelled serendipity. That is, you can come across surprising, unexpected events, surprising or unexpected circumstances, concepts, ways of thinking that you hadn't really thought about before. I think the most striking example of this was when my colleagues were doing some work on AIDS, when drugs were just becoming available but were quite expensive, and a lot of people were doing research into making these drugs more accessible at a reasonable cost to those who were suffering. But out of a lot of that research, and my colleagues were involved in some of this, came the idea that actually some people were making what to them was a rational judgment, that they simply were not prepared to allocate resources to treatment. They saw the expenditure on drugs, which would go on through their lifetime, as such a drain on household resources that they would prefer simply not to take the drugs if the alternative was to take their children out of school, reduce the household nutrition levels, and disrupt their livelihoods. They would rather suffer, they would rather die, if you like, than uh, pay for these drugs over their lifetime. And that was a surprising and unlooked for result which came out of qualitative study of these cases. What are the disadvantages of qualitative exercises, qualitative evaluation? I think probably the most serious is sample selection bias. This is simply a situation where by focusing on particular facilities, on particular people, on particular beneficiaries, on particular officials, you form a picture of an intervention which is not really representative of all of the other possible beneficiaries, officials, facilities you might have looked at. So we have to be rather careful, it's in fact very difficult, to be sure that we have put together a representative picture of how an intervention is operating, not just because we sometimes avoid the difficult places. We like to stay on the roads and don't venture off into the mountains, but also because sometimes we look for the most difficult cases. Sometimes we look for are the poorest people, are the most vulnerable people gaining access, and we might then tend to overlook the fact that a lot of relatively poor, but not the poorest, are actually doing quite well from the benefits of the intervention. So there are all sorts of ways in which we can get a misleading picture of what's going on, unless you're very careful about the potential biases that we may be pursuing. That's part of this difficulty of trying to cope with subjectivity. Every qualitative evaluator brings to their fieldwork their own bundle of concepts, their own bundle of hypotheses, their own bundle of understandings about how the world works. And it's actually very, very hard to move away from that. If I can quote just one example, I remember on one occasion being in a very poor community where the nurse in the clinic would see someone with a child, for example, with a fever, and they would sell them chloroquine, and then they would sell them a number of other drugs, tonics, vitamins, in order to make up increase the bill that was being paid. And for me, coming in and thinking with in terms of poverty, this seemed a really bad practice. However, one gradually came to realize that in fact everybody knew what was happening here, because those communities wanted the nurse to stay around. They recognized that if the nurse did not sell them other goods apart from the treatment they needed, then the nurse would simply not make a living, not be able to feed her family, and therefore would leave and go somewhere else. So these communities had come to an arrangement which worked for them. For me as an outsider, it looked rather bad. For them as a community which had to live there and wanted to maintain a reasonable standard of healthcare, it worked reasonably well. I had to get around my own preconceptions. Qualitative work, I said at the beginning, is difficult, and that means you really want people who are rather good at doing it, and those people can be quite expensive. You need seasoned, experienced, skilled researchers to lead qualitative evaluation. That can be quite expensive because often there's a lot of time is required to do this work well, to do your interviews, to collect your information, and that can be expensive. There is a problem which comes with the small sample size, which is that whenever you provide findings from an evaluation, this new way of providing services was proving quite effective. People then ask you, well, did it? What about poor women with small children? Was it good for them? and you think, well, how many women with small children did I talk to? And then somebody else will ask, well, what about the elderly in the community? Did it work for them? And you think, well, how many older people did I talk to? Did it work for elderly men as well as elderly women? And so on. And people will they will desire to know in fairly great detail, fairly disaggregated level, what kind of people were beneficiaries, what kind of people had access, what kind of people utilized the services. And that can be quite difficult if your sample size is relatively small. Each time you categorize, you cut down your sample size. As will be discussed in the next section on analysis, the problem which a lot of people who engage in qualitative evaluation don't really think about is the sheer volume of information which they tend to collect. When you sit with someone for an hour writing notes furiously in your notebook or using your digital recorder, you end up with a large amount of information from every single interview, and that generates over a period of time a huge volume of material to wade through and pick out the analysis. And sad to say, in many qualitative research exercises, most of the data is not actually ever analyzed. People just give up. They do quick briefs on the work they've been doing, and they stay at that level of analysis. They don't really get into that. They just simply don't have time to analyze the volume of data that they've collected. That means that you have to think rather carefully about just how much information you're going to be generating and how you can structure your fieldwork in order to make that information manageable in some way. Qualitative researchers always face the prospect of having their work described as anecdotal. I work quite a lot in China, and until fairly recently, really large-scale quantitative surveys or analysis of routine data systems was the only acceptable way of arguing for the outcome of an intervention. Anything else was seen as, well, you were just sort of walking around and talking to people, and you've just picked up a few stories and you've written up a nice report, but it's anecdotal. It doesn't really have evidence in it, and this is partly because the Ministry of Health in China is almost entirely run by doctors who are very used to the level of evidence provided in clinical research, not in social research. The flexibility that I mentioned previously means that we do often have problems around comparability between, for example, different locations. If we allow local definitions, for example, of poverty, then the poor in one village are not necessarily comparable with the poor in another village. And then we have difficulty in aggregating up to say, well, do the poor have access to these services? Well, without a single definition of poverty, that's very hard to compare. That's linked to the idea of to what extent are your results generalizable. A lot of people who do quantitative evaluation work feel rather confident in generalizing their findings. Basically, they've followed all the rules of statistical sampling. They've followed all the rules of estimation, and therefore they have the mathematics, the theory of statistics behind them, and they feel very confident that nobody will come to them and say, well, you cannot generalize in the way that you have, because they can just say, well, I've followed all the rules, and statistical inference allows me to generalize from my sample to the population. Qualitative evaluators don't have that body of theory behind them. They have to argue from first principles that what they did is highly likely to be representative of the the general impact of a given intervention. They have to argue their way through the generalization process rather than rely on the theory. It's probably been mentioned in previous sessions, but I think I should remind you again that when we do qualitative evaluation, it doesn't necessarily mean that all qualitative evaluators start within the same paradigm. So if you think about people who are working in an ethnographic tradition, this approach will mean that they're mainly thinking about long-term engagement with communities. We often use the word immersion. They're around, they're looking, they're listening. And their main activity will be around observing, listening, asking questions, but asking questions usually to clarify what people mean. The main task of an ethnographer is to find out what people's behavior, what people's words mean in a given situation, and how they can interpret what people are doing and saying. And that will often include participant observation. It will mean taking part in the harvest, for example, and learning about what kind of accidents happen to people at harvest time that need treatment, what kind of illnesses arise during and post-harvest. I work in a framework of rapid appraisal. It's known as rapid rural appraisal for historical reasons. My colleague of mine at IDS, Robert Chambers, developed the early work in this area, and he was working in a rural context, so he called it RRA, Rapid Rural Appraisal, but it's really about rapid appraisal. And it's using a set of techniques that are rather different from those used by the surveyor, for example, but nonetheless it's extractive. Again, my students hate this word extractive. They think it's a nasty word, and that nice people shouldn't be extractive. But that's what I am. I go into communities trying to extract knowledge from them, and I structure my evaluation activities in order to gather information. There may be, as part of rapid appraisal, and often are, joint investigations by research and community. So if we're drawing a community, a map of the village, then the activities will be undertaken by members of the community, led by the researchers. The researchers will be asking the questions, will be setting the parameters, and asking the community to assist them in generating information. But it's still an extractive process. The researchers are asking the questions and arranging how things are done. And in rapid appraisal, we will be using all the techniques of interviews, group discussion, mapping, timelines, and ranking that are also used by people doing participatory methods. But I'm rather strict in using the word participatory. I only use the word participatory if the agenda, as I say, is set by the community. And this is, if you like, non-extractive research. This is a research which is driven by communities. That's the only kind of work that I would regard as participatory. In that context, we talk about the researcher becoming a facilitator. They're supporting the community in undertaking the kind of research that they feel they want to do into, for example, a new project, a new program, a new policy. One would go to the community and say, well, the government has introduced this new policy. What are you worried about? What would you like to look at? What would you like us, if you like, to check up on, acting almost as research assistants? And the methods also, as a researcher, one might give a menu of options to the community and say, well, we could do this or we could do that, but the community should really make the decision. So, for example, the community might decide that they want to be involved in the logistics of drug distribution. They might want to be involved in the taking stock of what's in the drugstore and the accounting systems and so on and so forth. Communities don't always decide that they want to engage in community discussions or focus groups. Sometimes communities actually want quantitative evidence because they feel that will make a difference, that will impress policymakers. So in participatory work, my line is that all aspects of the research should really be driven by what the community wants, and the evaluator, the researcher, is then working for the community, if you like. Then of course we run into the question of who's funding the researcher, but quite a number of NGOs, for example, will fund that kind of activity by evaluators who are working with a community, working for a community in order to evaluate a project. Whatever frame we're working in, there are, I suppose, some common characteristics of qualitative work. One is that there is a strong focus on the local context, that the environment, the socio-economic context, the political context, the power balances. There is a concern with diversity. We are particularly interested, for example, in outliers. People who say that they totally disagree with everyone else. Everyone else thinks the project is wonderful, but they think it's a really bad project and is contrary to it'll prove unsuccessful in that particular context. So we're very interested in people who disagree with everyone else, and we're very interested in the unexpected happening. I was fascinated some years ago when I was looking at a rotating drug scheme where donors had set up a very elaborate system of building a drugstore and giving a key to the nurse who ran the local clinic and the head of a village committee which was overseeing the drug fund. And in quite a number of those villages, after about 6 months, the nurse and the head of the committee had gotten together. They were moving the drugs out of the drugstores into the local shop and selling them over the counter. I was quite fascinated, and I was fascinated because actually this system worked rather better than the one devised by the donors. The shop was in the middle of the village. It stayed open much longer than the drugstore was available. People more or less knew what drugs they wanted, as well as the people supplying the drugs. It functioned really rather well, and everybody was rather happy, except for the donors. There's a quote from somebody a qualitative researcher that I find quite impressive. And I think it captures some of the ways in which qualitative evaluators think. We're studying things in their natural settings. We're seeing what's happening as it happens. We're in the environment, watching and listening, attempting to make sense of or interpret phenomena in terms of the meanings people bring to them. So how do people see what's happening? How do they interpret? How do they react? So Tricia Greenhow is the researcher that I was mentioning, well worth reading. Approach that preserve the complexities of human behavior. And as someone who works both in quantitative and qualitative research areas, I find the freedom of qualitative research is really that it allows me to stay with that complexity. In a lot of quantitative research, we really can't deal with too much complexity. We have to simplify in order to design our questionnaires and our other research instruments. And it's quite a relief, in fact, to be working in a way which allows you to live with complexity. So what kind of data we'll be interested in, and how will our methods be useful for particular kinds of data? Well, qualitative methods are very useful in really in-depth understanding of perceptions and attitudes. It's really, really hard to capture the diversity of perceptions. It's really hard to get inside people's heads using a questionnaire unless you know an awful lot about the way in which people think. And usually we don't know a lot about the way in which people think. We're constantly being surprised by the way in which people think. So here I've given examples of how people perceive immunization campaigns. What do they really think these are about? And obviously that will vary enormously between one group of people and another. Attitudes to the risks posed by serious illness obviously depends on the degree of vulnerability and how people rate serious illness compared to other risks that confront them. Getting a really good idea of what community institutions, norms and values are is again extremely difficult to tease out using quantitative methods, but much more satisfactorily explored using qualitative. And collecting a lot of information in their own words. So one of the most powerful reports I've seen was actually from the World Bank, looking at impact of AIDS in Zambia, and there was an annex with around 20 stories of individual people coping with AIDS, telling their own story in their own words, and that provided a much more powerful and insightful picture of what it was like to cope with AIDS than all the tables in the rest of the report. And of course the traditional one for qualitative, where we looking at sensitive issues. So obviously the one most often quoted are where you're looking at a stigmatizing illness, where people are ashamed to have certain conditions, disfiguring conditions. Also very useful for looking at things involving power relations, where almost impossible to get at using questionnaires, partly because we usually refer to things as household questionnaires, and we don't have a one-to-one relationship between the person collecting the information and the person providing the information. It's collected by the head of household or whatever. By talking to individual members of households about for example, the way in which there are restrictions on the kind of healthcare seeking they can undertake, we can maybe see why some people have access to a new intervention and other people don't have access to that intervention. I thought I might give, to end this session, a very recent example which struck me, and this was a report in the Washington Post on a major trial, a very expensive trial, large-scale trial of an intervention to prevent male-to-female transmission of HIV, which was terminated early because it was clear from the quantitative evidence that it was simply not working. And I was fascinated by two of the quotes. The first one, my personal opinion, is the reason the gel was not nice. The daily regime wasn't acceptable for some reason. Now I found very interesting, because that's an almost completely useless statement. Wasn't acceptable for some reason. That gives me no clue whatsoever as to how I might change the intervention, modify the intervention so that it would be acceptable. And you kind of wonder, well, did nobody think about how to explore that question while the intervention was taking place? Second one, rather similar. What we have to face up to is everything in HIV prevention is based in human behavior. I found that quite staggering, that anyone should believe that everything in human prevention was not based on human behavior. And my immediate reaction was, surely they would have built into the intervention and the evaluation of the intervention something which explored the way in which human behavior would influence the outcome. So sometimes if you don't undertake the qualitative work in an evaluation, you end up with a failure, and a failure which you can't explain. Failure is okay. Failure is okay if you've gathered information which will allow you to move on to success next time, which enables you to learn lessons and incorporate those in the design of new interventions. But if you have a failure of an intervention and you have no idea, as seems to be the case here, why it didn't work, then your investment has been completely wasted. Thank you.